Okay, folks, I'm really sorry. Apparently, I was talking to myself. I hope that you can all hear me now. I had an issue here with my microphone, so I apologize for that. Okay, so I'm going to start again. So first, I'd like to welcome everyone. My name is Amit Binderman. I'm the CEO of Cometa Bio. We are the ones sponsoring this session. I think we've got a treat here. It's going to be a wonderful session. Thank you very much for joining us today. We already have over 100 people on the call, so that's fantastic. I'm impressed. Wonderful. Thank you very much all for joining. I see lots of friends on the call, lots of people we're working with. That's fantastic. So first and foremost, I really hope everyone here is healthy and well, and hopefully we're going to get through this crisis quickly. So before we start, just a quick administrative issue. Please keep your microphones, cameras muted. This is really going to help us maintain the quality of the broadcast. So thanks very much for doing that for us. If you do have questions, please use the chat box. Somewhere on your screen, there's a chat box. You can click on it and then you can type in your questions. We're going to do our best to answer your questions. But if not, we're going to take 10-15 minutes at the end of the session, and Professor Mazor will do his best to answer as many of those questions as possible. Okay? All right. So today we're going to talk about green dentistry, all natural. And we connect that with autologous procedures that are gaining much momentum today. Autologous procedures, and specifically we're going to talk here about dentin grafting, PRF, and such. Okay, can you hear me? Can you hear me?
Yes.
Good. Okay. So as I said, autologous procedures, dentin grafting, PRF, as a way to provide us with highly predictable outcomes for the long term of patients. So our presenter today really needs no introduction. Still, I will say a couple of quick words about Professor Mazor. Professor Ziv Mazor is a leading Israeli periodontist. He graduated the periodontal department of Hadassah School of Dental Medicine in Jerusalem, where then he served as a clinical instructor and lecturer for the undergraduate, postgraduate programs. Dr. Mazor maintains a private practice limited to periodontal and implant dentistry in Ra'anana, Israel. But personally, I think much of his time he's actually spending traveling to courses and lectures worldwide. Just looking at his itinerary is incredible. Since 1993, Professor Mazor is engaged in clinical research in the field of bone augmentation and sinus floor elevation. Some of that research you will see today. He is a well-published author on these subjects and has lectured extensively, both nationally and internationally. He has honorary memberships and in many associations, so I'm not going to go through the list. It's a long list. Dr. Mazor conducts advanced implant courses and workshops, and he's known for his out-of-the-box thinking and approach to dentistry. And definitely, believe me, you're going to see some pretty out-of-the-box amazing stuff today. I met Ziv, I think about 7 years ago. Yeah, about 7 years ago. And I was so impressed by his passion to teach, to mentor, and to share his experience with others or whoever wants to listen. I think you'll see a lot of that experience today. Since then, I was fortunate to hear Ziv lecture many times, but always it's new, it's fresh, and always out of the box. So with that, Professor Mazor, please, the floor is yours. Let us just, I'm just going to stop sharing and we can move the share to you. Okay. I can see you. Terrific. Just share your screen and we can start. Okay, go ahead.
Everybody. Do you hear my voice?
Yes, we can.
All right.
So first of all, I would like to welcome all of you, wherever you are on the globe. For some, it's probably early afternoon. For some, it's late evening. And anyhow, now, since we have a lot of spare time in those Corona times, I think we are going to have a little journey together in the next hour or so. And please feel free to ask as many questions as you have. I will try to do my best and answer all of them by the end of this presentation. Now, I want first to thank not just to Amit, but mostly to his father, Itzhak Binderman, which was probably the godfather of the treatment modality that I'm about to present to you today. So we are talking about green dentistry and using autologous dentin and what are the applications and indications for using that treatment modality. So yes, indeed, teeth can generate bone. And when I'm talking about green dentistry and applying those concepts in my practice, when I started to work with that, I asked myself, well, are you kidding me? How come nobody has thought about it before? And all thanks to Itzhak. I hope he's in the audience this evening. We are very close neighbors, maybe 500 meters from one another, but we see each other from time to time all over the globe. So there is a lot of availability of teeth. Teeth are extracted from different type of reasons, but the ones we are most interested in is, of course, teeth that are either broken or periodontally involved, or wisdom teeth that needs to be taken out. But also, as you will see later on, we can also use endodontally treated teeth. So at present, grafting of autologous bone is considered to be the gold standard of bone grafting. And we know that autologous is much safer than any xenograft or allogenic bone because there is no contamination and no immune response. But of course, with standard gold grafting of autogenous bone, we have a disadvantage, and that is the secondary surgical site. So the morbidity of the patient also plays a role. Now, if you look at it, there are lots of similarities between bone and dentin. First of all, they are embryologically originated from the same pathway. They are similar in composition to one another, and they both contain all those essential growth factors that we are talking about, like BMPs, IGF, PDGF, and TGF. Now, we know that dentin and bone go very intimately together because when we leave remnants of roots in the jaw, nothing happens. Those of us who are maxillofacials know that sometimes when we extract impacted teeth, we just cut the crown off and we leave the portion of the root inside the bone, and that stays there for the patient's lifetime. With all the partial extraction therapies nowadays, we leave deliberately the remnants of the teeth, either the buccal shield or sometimes the roots, and we know that they would function beautifully and they would stay very close to the bone without any pathologies. So alveolar bone and teeth can be inferred to have very high level of affinity to each other. What happens when we have tooth avulsion and we bring the tooth back? We get a term that we call ankylosis. And that means that there is a very strong bond from bone cells to the dentin surface. And you can see here the replacement resorption of the dentin by new bone, and that's what happens with ankylosis. So there is nothing wrong with ankylosis, and you can see the intimacy between the dentin structure and the bone structure. So what is the process? The process is taking teeth, which are extracted, and transform them into a graft material. And that is about 7 to 8 minute process. We extract the teeth, we clean them up, then we grind them in a special machine that looks to you maybe like a coffee grinder, but that is a tooth grinder. And then we take the particles and we clean, disinfect them, and then bring back the normal pH with a phosphate buffer, as I will show you later on, and then they are ready to use. Now, the protocol takes about 7-8 minutes, and you can see here some steps of the protocol: cleaning the teeth, dry the tooth, put it in the chamber, grind and sort, extract the graft, apply the dentin cleanser, which disinfects the particles, and then we apply the phosphate buffer saline, wash it twice, and then we can place the graft. If you want, you can also create blocks out of it. And my very dear friend, Nelson Pinto, which I'm sure that is here in the audience, has done a lot of work regarding the utilization and combination of PRF and dentin. So here you can see a typical example of a dentin block that can be, of course, utilized for any type of regenerative purpose that you wish. And that is what everybody is showing as sticky bone. We're talking about sticky dentin. So we love dentin and we love PRF. That is especially for you, Nelson. So here is a close-up of a PRF block. And I don't know if you know, but Nelson, myself, and Chuck Schwimmer, we belong to the Outside the Box Club. So you can see nicely here the PRF block on a SEM electron microscopy. The dentin cleanser, which cleans the dentin, has a very interesting property. It contains natrium oxide and 20% ethanol with a pH of 11, and that destroys all the bacteria, yeasts, fungi, and endotoxins, and probably also the coronavirus. So you can see on the left the dentin before cleansing, and on the right after the tubules are open and cleaned. Now, there was a myth that teeth are nothing like bone. Well, that is completely wrong, because you can see that the composition of the tooth resembles very much so the composition of bone regarding the percentage of HA, collagen, water, and growth factors. As a matter of fact, you can consider the enamel of the tooth like a super xenograft. The HA particles that most of us were using over the years are like the enamel particles. The dentin is like a super cortical graft, and we will talk in details later on about the resemblance between the tooth structure and the graft materials that we have been applying over the years. Now, what about the pulp, the nerve, and soft tissues? Well, they are not left with the grinded particles. So the only parts which are grinded are the enamel, the dentin, and that's it. Here you can see a typical example of some teeth that I grinded, and you can see that the pulp remained intact in the chamber. Sometimes it also dissolves due to the effect of the cleanser, but it will never be present in your graft material. What about the bacteria that are on the root? Are they destroyed? Well, you can see here on the left the dentin cleanser, which destroys all the organic deposits and bacteria. On the right, that is the phosphate buffer that brings back the normal pH. And my very good friend Nelson Pinto did a very nice study comparing the effectiveness of the cleanser versus gamma irradiation. And he found 0 bacteria in both. So that was an ad in Time magazine, as you can see many years ago, teeth for sale. Well, maybe in the near future, we will see some more ads like that, because teeth really can be utilized. And sometimes they are very expensive, like John Lennon's tooth that was sold for $32,000. So keep the teeth. Now, the validation was done by Professor Binderman, and he did first an in vivo model to test the bioactivity of the dentin, and he injected dentin particles together with fresh marrow subcutaneously under the skin of a rat, and he found, surprisingly, new bone formation next to the dentin. So that gives you the activity of that graft material, which stays very close to the bone with very direct intimacy. Second phase was to graft extraction sites. That was done in mini pigs, and then inserting implants into the grafted sockets. And you can see beautifully here on the histology, on the left, the implant surface, and the close contact to the dentin bone interface. And you don't see any activity of osteoclasts or any other giant cells. So very close adaptation between the bone and the dentin. That is a histology that was taken from a human specimen after 2 months, again showing very nicely the interface between the autologous dentin and the new bone formation. That is another great documentation done by Chuck Schwimmer for socket sheet. And you can see new bone formation on the right-hand side next to the implant opposing the dentin. So again, that is Chuck, my good friend, in one of the courses where we needed some samples for grinding. So we took and pulled out his wisdom tooth. No, I'm just kidding. So graft should turn over fast. That was one of the myths over the years. Well, we know today that that is wrong. We don't want a graft material that would resorb too quickly, as some of the graft materials are. So we want to create a scaffold, and that scaffold has to stay in the area until new bone formation is established. And if the scaffold is removed too soon, we will have immature bone that will start to resorb. So we do want a material that would stay longer, but still would be able to remodel later on. Does the dentin graft turn over? The answer, of course, is yes. Now, we have 2 sizes of particles created in our dentinal grinder. The small particle size is under 250 microns. Those will resorb quite quickly in about a couple of months, 2 to 4 months. The large particle size, between 250 to 1200, would resorb between 10 to 14 months. So we can play with those mixtures depending on what we want to establish. Is the material osteoinductive? Yes. It attracts progenitor cells that differentiate into osteoblasts. And it contains BMPs. Now, we know that those BMPs are concentrated inside, and they can also be utilized a long time afterwards. So if you ask yourself, what about the graft itself? Would we have enough graft material regarding volume? Well, again, from a conventional canine, we can get up to about 1 cc of graft material. From a premolar, 1.5 to 2 cc's. And from molars, around 2.5 cc's. So we have plenty of material. One of the questions that I'm being asked all the time, can we store the graft material? Again, the answer is yes. We can store the teeth almost indefinitely, but again, for the same patient. So over the patient's lifespan, we can utilize his teeth that were exfoliated or extracted by the dentist. So that is a nice study by a German anatomist named Schultz that was published in 2005, showing there are intact growth factors conserved in the extracellular matrix of ancient human bone and teeth. So that means you can use those teeth indefinitely. Some of the studies out there all started many years ago. Take a look, 1986, osteogenic potential of autogenic demineralized dentin implanted in bony defects in dogs. Another one by a Japanese group, 1990, purification of rabbit bone morphogenic protein derived from bone, dentin, and wound tissue after tooth extraction. The Korean group, led by Kim, grafting of large defects of the jaws with a particular dentin plaster of Paris combination, 1999. And that is the highlight of Professor Binderman's work in 2014. Again, sorry, that was not Binderman. That was, again, the Korean group, but based on those articles and by Itzhak work, 2014, novel procedure to process extracted teeth for immediate grafting of autogenous dentin. Frank Schwartz, that most of you probably are familiar with, did a nice study in 2016, again, showing case reports of extracted tooth root used for lateral alveolar ridge augmentation. And the list goes on and on. That is quite a recent article that was published by Avi Kupperschlag. I think he is also here among us today, showing the use of impacted third molars to be used and utilized for bone and socket regeneration. One of my dear friends from Croatia, Dr. Snezana Pol, I think she's here also tonight with us, did a marvelous study of maintenance of alveolar ridge dimensions utilizing an extracted tooth dentin particulate autograft and platelet-rich fibrin. And what she actually did is they extracted teeth, they measured pre-op CBCTs, and then after 4 months, they measured again and did a superimposition of those CTs. That's really, my friends, hard work. And what we actually see that not only they were able to preserve the dimensions, for vertical height, they even got gain of height of about 0.16, while for ridge width, they lost about 1.38 compared to other studies on xenografts that lost 2.5 to 4 millimeters. So that's a very big advantage. This is a publication that we did last year at the IJPRD, showing the healing dynamics following alveolar ridge preservation with autologous tooth structure. And what we were able to show here is that after 7 months, what you see here on the histological slide, 85% of new bone and only 15 of residual dentin. So we have lots of advantages by using the dentin graft material. It is an autologous graft, which is considered to be gold standard. It is mineralized graft, contains growth factors, and of course makes induction for new bone formation. It release of natural growth factors. It has a strong osteogenic properties. It's readily available. There is no need for a secondary surgical site. We can use it not just for horizontal or extraction defects, but also for vertical augmentation. And of course, it's a slow resolving material, which has a lot of advantages. And I know a lot of us sometimes are using a mixture of graft materials like mineralized allograft, and xenograft. I think dentin is the equivalent to use those instead of using those graft materials. How do patients react to that? Well, I can tell you, they love it. And why? Because you actually take something from them and you give them back. And I didn't find any objection of any of my patients by offering them to bring them back what I took from them. And of course, financially, sometimes it can also reduce the cost because you don't need membranes, you don't need graft materials. There is almost no inflammation and very little pain with those procedures. So let's take a look at the clinical applications using a grinding tooth substance. And I made some subcategories, and I will be showing you one by one. So we will start first with socket preservation and augmentation. Here is one of my patients coming to the office with a failing second molar, mobility class 3, a perio, huge defect and an abscess. And of course, we decided to extract the tooth and use the tooth as a graft material. So we extract the tooth atraumatically, clean it out, put it in the chamber, grind it up, disinfect the material, and here you can see that we rarely raise a flap. And there are lots of articles nowadays showing the huge advantage of not reflecting major flaps. And you can see here that by just pushing the gingiva away, we also have a huge and big defect on the buccal aspect. But nevertheless, we are filling up the defect with our dentin and cover everything here with a non-resorbable membrane. So the gingiva is sutured. 3.5 months later, we open up the area and we have complete regeneration of the defect. Now, I cannot tell you just by looking, like Bill Becker was saying, that if it looks like bone and tastes like bone, probably it's bone. Well, it can be bone only if you see it in histology, and you will see it later on. So now we can insert an implant according to all our parameters, finalize the prosthetics, and here you can see from the same patient, that's a 3.5 months specimen, showing you very nicely the dentin and the close intimacy of new bone formation in between all those particles. Again, you can see a nice particle of dentin surrounded with new bone formation. Here is one of Nelson's cases. So we have a hopeless molar here with a fistula. Nelson is dissecting the molar, extracting the roots, taking PRF, of course, extracting the third molar, which is going to be the graft, the source for the graft material, creates a PRF dentin block, and pushes the block into the extraction socket. And you can see a 7, 10, 14, and 21 days of healing. And you can see nicely how the gingiva heals very, very quickly. Now, when we use and utilize PRF, we can, of course, leave it exposed because the PRF has an antibacterial effect and it will promote quick angiogenesis. So here it is on 30 days, and here you can also see the ridge dimensions, which are preserved beautifully. So you can see the before without any buccal plate and the after. Then comes the time for implant placement, and again, PRF is utilized, and here you can see the bony specimen that Nelson took, showing you beautifully some remnants of dentin and the close intimacy of new bone formation. Implant is inserted, quick gingival healing, and that is still the temporary with perfect healing of the gingiva. Here is one of my periodontal patients. She has aggressive periodontitis. As you can see, the first two upper molars, of course, are doomed, same as the lower molar, and you can see a huge infrabony defect here, which is about 7 or 8 millimeters deep. So I decided to extract the molar and use it as a graft material to do socket preservation, because I would like to place an implant later on. Now, that was a case that I treated, I think, probably 7, 8 years ago. Today, probably I would have placed immediately the implant with osteodensification. But then again, what I did here is I grafted the tooth. Not only that I did socket preservation, but I said, well, let's try and also fill up the infrabony defect around the second molar. And let's see what happens. And I applied Schnezana's principle of Robin Hood therapy. So we cover the graft with a membrane, nice soft tissue healing. 3 months later, I take an X-ray and I'm starting to, open my eyes, and I really don't believe what I see, because I was looking for the huge defect, the intrabony defect of that second molar, but everything now is closed. I'm trying to probe the area, 1, 2 millimeters of probing, that's it. So I said, well, let's find out what's happening on the CT scan. So I do a scan and I take a look, and by the way, if those of you are seeing the white spots here, those are the particles of the enamel. You know, the enamel is HA. HA probably would stay there almost forever. And again, look at what we started with and where we are. We have regeneration. I mean, it will be true regeneration if I would take a block section of the tooth, but that's not my intention. So again, you can see the reformed ridge, implant placement, and again, I took a biopsy, and here you can see one of the most beautiful biopsies. You can see here on the left, denting, new bone formation, enamel particle, and again, new bone. So you can see very nicely the intimacy between all those particles and how they live very happily together. Implant insertion, post-op CBCT. Again, you can see very nicely the new regeneration that we got by using the dentin particles. Time of implant exposure and fabrication of a screw-retained zirconial crown. So that was with socket preservation and augmentation. What about implant gap fill? Here is a case, again, of a patient with periodontitis. He needs some extractions of the root here and also of the first premolar, because there is almost no bone present there. And you can actually see the huge defect around this canine. So we extracted the canine, and of course we are not throwing it to the waste. We clean the tooth, put it in the grinder, and use the graft material to fill the gap around our future implants. So you can see that 2 implants are inserted here, and I cover the gap around the implant with a combination of PRF and dentin. Cover everything with PRF. And here's the post-op. Now, when I exposed the area, I had new bone formation on top of my cover screws. And when I was going to the canine area, I simply had to grind off bone from the top in order to get to the implant. So we had very nice regeneration. Here is another case, failing all the implants, failing an old tooth. So we extracted the bridge, and you see we have one tooth here and also one root. Why not utilizing it as our graft material? So actually that's what I've done. We cleaned them up, sterilized that with the cleanser, inserted new implants. Now I'm going to graft the gap around the implants with my dentin material. And here it is, just 3 months later. Remember how it was on the left? That's what we got on the right, just by applying this type of graft material. Now, if I would utilize here, let's say, anorganic bovine mineral, I would still be left with that crap afterwards. All right. Patient comes in. She has class 3 mobility on the upper left central, no bone surrounding it. Anterior maxillar area, aesthetic nightmare. Now, tooth is completely mobile, so there is no even a chance of maybe thinking about socket shield or so. So what I decided to do here is I took out the tooth. Of course, you don't have to apply too much pressure into it. And I sectioned the tooth into 2 parts. Now, some of you probably know exactly why, because I'm going to grind the apical portion and fill the gap around my future implant with the dentin, and I'm going to utilize the crown as a temporary. So here is the case after extraction, placing the implant in the right position, that was before Versa times, and utilizing the patient's own crown as a temporary. I'm filling the gap and taking an abutment and securing the crown together with the temporary abutment. And you can see that after 1 week of healing, you can hardly say that there was any type of surgical maneuver done. And of course, aesthetically, I would never be able to give the patient something which will be more aesthetic than her own existing tooth. Now, since she wanted to close the gaps a little bit, we decided also to do some laminates on the front. And here, by the way, you can see on the left side how the buccal prominence was preserved. So we took impressions, we did some laminates, and finally, she was very, very happy, and that is maintained now for almost 8 years now. Perio-infrabony defect field. Well, I showed you one case. Let me show you another one that I just treated accidentally. That was a lady that I placed a couple of implants here with some bone expansion at that time. And that tooth was for extraction. And you can see that there is a huge circumferential defect around that tooth. There was also another wisdom tooth that I needed to extract. So I extracted the tooth, grinded it, and then I went, that was a class almost 2 to 3 mobility in molar here. And I took those dentin particles and I grafted circumferentially around that tooth. Well, there is nothing I can lose here. So here it is, 3 months later. Again, I was rubbing my eyes. I didn't believe what I'm seeing. But the tooth got so stable without any mobility, no probing depth. So of course I left it intact. Bridge augmentations. Well, here is a typical case of a huge defect that probably most of you would consider in creating all kinds of surgical maneuvers like titanium mesh, dense PTFE membrane with titanium reinforcement, and so on. So that is the situation. You can see that there is no buccal plate here on the buccal aspect. That is the left side. So I took out the bridge, and you see it comes in one piece because everything is mobile. And I'm not going to throw away those teeth because I'm going to utilize them as my graft material. So we did first a frenectomy with laser, and then we took those roots and we are utilizing them to create our graft mixture. We clean all the soft tissue, the granulation tissue out, and now we are starting to make our immediate socket implant placement. I did it everything here in one shot. And of course, we have to graft all the big defects. So it's a combination of dentin, and on top, I placed here also calcium sulfate and PRF, of course. See, Nelson, I'm not forgetting you. So we close up the area and we deliver immediately and temporization, and look how nicely the soft tissue are healing, and there is a complete reconstruction and maintenance of the buccal architecture of the ridge. Final PFM with pink porcelain, and take a look at the befores and the afters. And remember, there was no membrane utilized here. Crestal sinus augmentation. Well, I think I've done maybe a few of those in my professional career. Here is one old case. A lady comes in, she's going to lose her first molar here. So we extracted those hopeless teeth, used them as a graft, insert our implants, and I'm going to utilize dentin as my graft material. Now, how can you tell that this is an old case? Well, you can see this instrument here, which is called osteotome. Well, in prehistory, I was using those instruments to do closed sinus augmentation. Well, not anymore. Today, those instruments probably could be sold on eBay in auctions. But since we've started to use osteodensification, we don't utilize those monsters anymore. So we did close sinus augmentation with the dentin particles. Also, you can see here socket augmentation at the same time. And on the left, you can see the pre as opposed to the post-op CBCTs. Patient is very happy. I think it was like 9-year case, or maybe even more. She's very well and functioning, and she came just for a visit a couple of weeks ago. And then I found out that her dentist did not load all the implants. He left one implant here unloaded. I don't know what was the reason, but anyhow, you can see how the integrity of the bone is maintained for 8 years. Now, that is a nice case that I've done 6 years ago, and it was done 2014, which for me was a turning point in my professional career. Why turning point? Because that was the year I met Salah Huwais, and he changed completely the way I practice today in my office. And that is due, of course, to osteodensification. So that was the first case I did with osteodensification. You can see here an existing ridge of 4 millimeters and the hopeless premolar that needs to be extracted without any buccal plate. So I took off the bridge and I'm utilizing my magical burrs here, the Versa drills. We are starting to do the preparation. We extract the tooth, and of course, we are going to utilize it as a graft material. So here's the graft injected into the osteotomy. Implants are inserted. And now we go to the front where we didn't have any buccal plate, and we are simply doing a socket site preparation with Versa, and that will shift the bone from the palatal aspect to the buccal aspect, and will give me the opportunity to place immediately an implant with a high insertion torque and high stability. And you can actually see that the day of surgery, we loaded the last tooth and this first implant. And I said to myself, well, if it doesn't last, I would do a new implant later on, but at least I would protect my sinus graft area. So here it is, just 6 weeks later, 8 weeks, 3 months. At 4 months, I sent her to a new CBCT. And when I looked at the clinical, the radiographical images, I simply was very, very happy, because this is the way I would like my graft to look like. I don't want it to be very opaque and particles like with anorganic bovine mineral. I want it to resemble new bone. That's exactly what it looks like. That is a 5-year post-op of that case. Another one that was done about 6 years ago, upper right side, failing old bridge, not enough bone to the sinus, about 6 millimeters or so, extraction of the bridge, cleaning the teeth, doing crestal osseodensification. Here it is, the before and the after. And since I had so much primary stability, I decided to immediately load those implants. And you can see the implants with the stock abutments and the post-op CBCTs. And finally, after 3.5 months, final prosthesis is delivered. That is the same lady I showed you with the infrabony defect with the aggressive periodontitis. So we are going to lose that upper molar, and we need sinus. Now, most of you probably would say, well, this is a case for a lateral window. Well, I did agree with you if you would have asked me that 6 years ago. Today, that's a completely different story. So here's the case. We grind the tooth to be our graft material. We start osseodensification, and we have protocols nowadays that we established according to the difference in the vertical bone height, the residual bone height. So even in cases with 2 millimeters, not a problem to do osseodensification, as you can see here. And we place the graft material, we lift it up with our burrs according to the protocol, insert the implants, high stability, and you can note the post-op CBCTs 3.5 months later, 4 years later. Lateral window sinus field. Well, those of you who still enjoy to create morbidity for your patients, that's your call. So here's a case I did about 5-6 years ago. I decided to do a lateral window here using the patient's teeth, which were hopeless, clean them up, grind them, and then, of course, creating the lateral window. And here is the dentin, which is stuffed into the maxillary antrum or sinus. That is right after the surgery, post-op CBCT, time of exposure, abutments, and final restoration in 7 years. So long-lasting treatment modality. Combined therapies. Well, here is a case of a lady that needed extraction of teeth. You can see here on the left side, we did sinus augmentation utilizing dentin as graft material. You see implants which are inserted with very high stability, even though we had about 3 or 4 millimeters of residual bone height. And on the other side, we extracted the tooth. There was no bone whatsoever, not in the buccal, not in the palatal. So we decided to do dentin graft socket preservation. And we came back 4 months later and take a look at the bone that we established after 4 months. So now we can go with our Versa drills and do a sinus augmentation done into the dentin particles. So here it is. You can see the left side with a post-op CBCT, and the same case after 2 years in function on both sides. Now, that's an interesting case done by one of my friends, Dr. Stuart Molloy from Paris, France. Stuart is one of the dentists that I really give credit to. He was a prosthodontist for many years for a famous French implantologist, Davarpana. And Stuart, I met him first few years ago when I was doing a course at the IDEA Institute in San Francisco. And ever since, he comes almost every year, at least to 1 or 2 courses that I conduct. And he sent me one of those cases that he treated, and I want to show you how he applies all the principles we are talking about. So that is Stu on the right-hand side, and that is a patient that comes probably from either Saudi Arabia or one of the Gulf countries, patients that he likes to treat in Paris. So complete edentulous maxilla, complete clearance, utilization of osseodensification and immediate socket implant placement. And you can actually see how he extracted the teeth, grinded them up, applied PRF, of course, and all that mixture was placed mostly on the buccal aspect to maintain the integrity of the ridge. So you can see the before and the after. Maybe still I would place 2 less implants here in the front, but that's not really a problem. Temporization. And here is the bottom side. The problem here was that there was almost no ridge available. And I still remember how Stu gives me a call and he asks me, well, what should I do here? So I told him, well, extract the teeth, use, of course, dentin, and place not just the mini implants, but place also tiny implants to secure a temporary ridge. So here you can see the ridge after extraction and cleaning the sockets, how the narrow diameter implants, there are 3 millimeter in diameter, are placed here, and in between you see the screw retained prosthesis done on those mini implants, which are 1.8 to 2.2 in diameter. And they give you the ability, after you see nicely the grafting of the PRF and dentin together, and the post-op CBCT showing you also the ridge dimensions. And that is the temporary that was delivered to the patient after the surgery. So here you can see a 6-month follow-up with conservation of the ridge defects. And that was a pinpoint knife edge ridge. And that is the final. Here is another nightmare. Patients comes into my office. Someone had done implants like 15 years before, and he is a complete negligent patient. He doesn't brush. Lots of inflammation. hardly has any bone in his existing teeth. So definitely this is a case for complete clearance. There was only one implant here that was still in a good condition. You see the other one was placed right into the incisive foramen canal. That is the clinical appearance. So the lower jaw doesn't look much more promising, but we can utilize the teeth as a graft material. And of course, you have to change the habits of the patient, because if he doesn't maintain and doesn't brush, don't even start doing the procedure. So we take off the old crowns, we take out the implant. We have plenty of material to work with and to create a lot of graft material. So we mix it with PRF. Of course, we can create PRF blocks. We did a crestal sinus here, and still at that time I was using osteotomes. So you see that's not a fresh, new patient. PRF on top of everything. At the same appointment, we placed all the implants which were needed, and we fabricate a temporary provisional bridge. Now, this is the amount of material that was left after we finished all the grafting procedures. So it gives you a hint of how much material you can get from one procedure. You can note that I loaded some of the implants, not all of them. Those in the sinus, I didn't want, of course, to immediately load them. Now we go to the lower. Complete clearance, cleaning, fabricating the graft material, placing the implants, and we create a PRF block. And here there is a short video that will demonstrate to you how we can create a dentin PRF block. So first, of course, you have to know how to do phlebotomy. And once you are familiar with how to do phlebotomy, then it should be an easy procedure and a must procedure in every augmentation that you perform in the office. So we are using the protocol of LPRF, which says 2700 RPMs for 12 minutes. We clean the teeth from all the calculus, remnants, old fillings are taken out, of course. Grind them for 3 seconds and sort them for 20 seconds. And then we can collect the graft material from the chamber. Now we have to disinfect with the cleanser. And remember, that was a 5-minute procedure. And after finishing with the cleanser, we would twice use the phosphite buffer saline, rinsing it twice. Here are the PRF, that is the solution that is taken after 3 minutes of spinning with the white cap tubes. And those are the PRF pellets that we get from the spinning after 12 minutes. And that, of course, will be utilized together with the graft material. So we put it in the box for a couple of minutes. And after a couple of minutes, we have the membranes ready for use. Now here, what we do is we use a Mediterranean recipe, which is called couscous. So we chop those membranes into small pieces, and we will mix those small pieces with the dentin mixture. And to the mixture, we would apply the liquid, which contains fibrinogen. And after 15-20 seconds, we will have a nice clot that you will be very proud to show as sticky bone or sticky dentin. So we are applying the sticky dentin here, cover everything with PRF membranes. And you can actually see, even in those huge defects, I can still place my implants, graft them with dentin, and cover them with PRF membranes. So here it is after the surgical procedure, and I immediately loaded it on some of those implants. Here is the post-op CBCT of the upper jaw, before and after. Taking impressions, taking inter-arch relations, and fabricating the metal framework for screw retained prosthesis in the lower jaw and the PFM porcelain reconstruction on the upper jaw as well. You can see here the post-op CBCT of the lower jaw and the final restorations that were delivered to the patient, and a 6-year follow-up. And now he's one of my best patients regarding oral hygiene. So stop, do not discard extracted teeth, because you can recycle patients' own teeth for the benefit of your patients. Now, a question that I've been asked a lot is, can endo-treated teeth be utilized for dentin graft? And the answer is yes. Although the tooth is non-vital, the collagen, the growth factors, the BMPs are still active and present. And we can definitely use those teeth in the same manner. But you have to make sure, first of all, that all the gutta percha is taken out, no residual cements are left in. So you have to drill it out, and sometimes you have to section those teeth vertically in order to take the gutta percha out. Now, if you have vital teeth, of course, that will be my first preference. So I don't really like to hassle a lot, but if you don't have any other choice, yes, you can utilize non-vital teeth as well, as you can see here. So let's sum it up and see what are the values of using dentin graft material. There are economical values like cost-effective graft, saves you money regarding graft material and membranes as well. It reduces the graft inventory. You get a lot of volume from pre-existing teeth that you extract. And it's very easy to explain and get the motivation and acceptance of the patient. Clinically, it's still considered the gold standard of grafting from the same patient, autologous. It gives you an easy and simple process. There is no problem of a secondary site. You can store and use the graft for a later stage. It's bacteria-free, as I showed you. Low resorption, and I think that is very equivalent to what we have been utilizing with xenografts and allografts together. Has a very good potential of osteogenicity and osteoinductivity. Slow release, and of course, attraction of progenitor cells. So altogether, I think it's a major advantage. Now, is there enough science to support it? Well, you can see some of the publications that are out there already on dentin graft material. And the list goes on, and you can actually see every month some new articles and studies which are published. You can go also to Commento Bio's website and download some of those publications as well. So as you can see, there is lots of literature out there. Now, who is using it? Here are some of my best friends that we are a group of dentin lovers, and you probably recognize all of them. Some are here with us tonight. I know Shnezana is here. I know Nelson is here. I hope my other friends are here as well. So the destiny of extracted teeth should not be going to the waste. So in order not to waste your time, do use those extracted teeth. Now, I would like to take this opportunity and invite all of you to our new teaching facility that we built up in Tel Aviv, Israel. This is part of Versa Osseodensification Academy programs, but also we run a lot of hands-on courses on different subjects. You can see here some of the faculty which helped me to deliver those courses. Among this faculty, there is my good friend that you see here on the picture, Roberto Rossi from Genova, Italy. We have Samuel Blyen from Moscow coming and deliver on soft tissue around implants. We have Nelson Pinto that was supposed to come just a few days before Corona time, and I'm sure we will reschedule another course with him. We have George Kotsakis on periimplantitis. We have Yanis Vergoulis and Mitzias Militiadis on root membrane therapy. We have Patrick Palacci. So all the good guys, together with Howie Gluckman, of course, all the good guys are coming, and we share all together the passion and desire to teach all those dentists out there how to learn from our mistakes and our experience. So with that, I want to conclude and give you time to ask questions, and I thank you very much for your attention. And I'm very glad that nobody left the webinar.
Yeah, it's fantastic. We still have 160 people on the call. Wonderful. Professor Mazor, fantastic job. Thank you very much. I've seen the presentation. I saw the presentation yesterday, and I got to say, I'm still finding new things that I guess I missed. And especially the variety of different indications that you're providing, some very, very cool work. Lots of questions are being asked. I don't think we're going to be able to cover all of them, but I'm just going to start with a few here. There was an interesting question about bone resorption around dentin grafted sites. Based on your experience, have you seen bone resorption around these grafted sites, and what's your take?
Well, interestingly enough, I see a different phenomena around sites that were grafted with dentin, as opposed to sites that I grafted, let's say, with an allograft, because I don't see any shrinkage and I don't see almost no resorption. So to my opinion, that's a very good advantage.
Yeah, just to add to that, there is a great paper that Dr. Shnezana Paul just published. I think it was a month ago.
About it.
Yeah, I know, but I think it's very relevant because she's showing the vertical height maintenance of sockets, extraction sockets, and really it's a paper that I hope you guys have a chance to download and take a look at. It's beautiful. The data is really amazing. Periimplantitis is another question. Have you been using this with I know you showed one case, I think. Can you say more about how you're using this with periimplantitis cases?
Well, I'm using it in periimplantitis cases exactly the same way I was using the other grafts before. The main issue with periimplantitis is to try and clean the infected implant surface. That is the key point. So if you don't clean the implant surface, there is no magic material that will bond to the surface. So that is a key factor. Since it is a slow resorbing material, I think there is a big advantage of using it in periimplantitis cases.
Okay. There was a question here about, can you use dentin graft without PRF?
Of course. I showed you some cases that I used just dentin graft without utilizing PRF. So what you do is just mix it with your solutions, sterilize, and then bring back the normal pH, and then apply it directly to the defect.
Okay, okay. Ziv, our dear friend Sandeep Singh from India is asking.
Hello, Sandeep.
He's asking about simultaneous placement, and what's your opinion as far as the minimum residual bone height that you prefer to see for immediate placement?
Well, for immediate implant placement, where? In the sinus?
Simultaneous placement. I'm not sure. Well,
it doesn't really matter.
Actually, is that okay? Not sure if he's clarifying here. He just sent another question in. No, Sandeep, if you can hear me, if you can clarify that question. Meanwhile, let's go to the next question. Also from Sandeep, do you prefer barrier collagen membrane on top of the dentin graft?
Okay, that's a very good question. I was using lots of membranes in the past, and in the last recent years, I backed a little bit from that. And it all depends on what type of graft material you are using. Because I found out that using the dentin graft, sometimes I don't really need a membrane because it doesn't resorb quickly. I always utilize PRF on top of my graft material, so maybe that is a partial answer to my philosophy. And to tell you the truth, when you don't have huge defects, you don't really need a membrane because the membrane will just slow down the healing process. We have lots of growth factors over there, autogenous growth factors, and PRF, and they speed up the regeneration process. So not always you need a membrane.
Yeah, and there's one more thing I would add, and that's something studies I know are currently taking place. I know a few people are working on it, including Snezana Paul, and that's showing that you don't really get invagination of soft tissue into dentin graft. And that's another reason why you don't necessarily need a membrane, because you do need a membrane for dimensioning to keep the dimension of the sock of the side, but also to keep the soft tissue out. In the case of dentin graft, autologous dentin graft, you don't really see that. Would you agree?
I do, 100%. Well, I agree with everything Snezana says.
And Dr. Singh actually did clarify about the minimum residual bone height in the sinus.
Well, since Sandeep knows me a little bit, and most of you probably do, I really don't care about the height of the residual bone between the sinus and the ridge. And we have designed even the fourth protocol for DENSA when we have only 1 to 2 millimeters of residual bone height. So the height is not really a factor. Of course, I will not immediately load those implants, but they can still be placed simultaneously together with the sinus graft.
Okay, okay. Question about how to store the graft. So sometimes, as you showed, you're grinding a tooth or couple of teeth, and you have...
Yeah, well, there are two options of storing the graft. If it's a intact tooth, then you don't need to do anything. I just put it in a small box and I give it to the patient to guard it. And when we need it sometimes in the future, he can bring it. Because I don't like to have a tooth bank in my office and store all patients' teeth. That's not my intention. But yes, that's one option of preserving the tooth for a later stage. Another option is when you already grinded the tooth, you have to first dry it, and you can use like a coffee warmer to dry the material, put it in a closed sterile bag, and you can store it in the refrigerator. And don't forget, when you come back and you want to use the material again, to do again the cleansing and then following the protocols.
Right. Yeah, that's exactly right. And we have protocols for all of that on the Cometa Bio website. You can download these protocols. All of them are there. There's also another protocol. I can't recall if you mentioned it, but for the past 2 years, we've also introduced a protocol for partial demineralized dentin graft. And we like to use that. It's really just adding 2 more minutes to your processing. So if the whole thing takes 7 minutes, with the partial demineralization, it takes 2 more minutes. It's another liquid. It's EDTA, and that's demineralizing about 20% of the graft. We really like to use that because it's exposing a little bit of the collagen, and so it's instigating the healing process earlier on, quicker. So when you've got patients that are, are going to be slow healers, like smokers, diabetic, medicated, we like to use that process. Professor Mazor, what has been your experience with the partial demineralized graft?
Well, there are lots of studies in the literature showing a beneficial effect of using partially demineralized dentin. And I've used partial demineralization in many cases. I like to use it in some problematic patients with slow healing, and in smokers, for instance, diabetic patients, and so on. And I think it has only an advantage. So feel free.
Yeah, wonderful, wonderful. Just a quick answer here. Lots of questions from India, by the way. So wonderful. Thanks very much for the Indian contingency on the call, asking if the grinder is available in India, and it is. It is sold by Sark Healthcare out of New Delhi by my dear friend, Mr. Sunil Sharma. Okay. Yeah, what about combining it? If you don't have enough from a single tooth, let's say you only extracted 1 tooth, you're getting about, from let's say incisor, you're getting about 0.5 cc, and you need more. Can you combine it with other grafts?
Sure, and sometimes you don't have enough, so you can mix it with another type of graft material. I have some cases that I've mixed it with an allograft, and that worked beautifully. Mixing it with xenograft is not really my best choice, but only if you don't have any other option. But certainly I've used it by mixing it with an allograft, and it works exactly the same.
Okay, wonderful, wonderful. So I think we're going to wrap up. We just wanted to mention that the recording, this has been recorded, and the recording, it will be available to you. So either you can contact us directly on info@cometa.bio, or we will send out a general email with a link to the recording, so you can access that. Also, many webinars and videos on our YouTube.
And by the way, I just forgot to mention that all of you are invited to my next webinar tomorrow, which will be on a different topic. It will be on outside the box in implant dentistry. So it will be on Facebook, and you are most welcome to join.
Wonderful. At what time?
It's, I think, 4:30 in the afternoon, Israeli time.
Okay, so that's about 10:30 Eastern.
And that is part of the Global Implantology Summit meeting.
Ah, okay. Wonderful. Very good. So anyways, for more information, you can always contact us directly at info@cometabio.com, and we'll do our best to introduce you to dealers in your region, answer questions, provide you with protocols, cases, and everything else. And also lots of information on the website. And you can also
don't forget, after the Corona time, you are all invited to come to Tel Aviv.
I'm the first one there. I can't wait. And also check out our YouTube channel. So YouTube/Cometa Bio, where you're going to see, again, lots of videos and information about the procedure. It's been on the market now for 7 years, so tons of experience. And we actually have more webinars coming, and we'll be happy to include you on the email blast for future webinars. The next one actually is going to be in Italian, and that's on the 30th with Ziv, your friend, Daniele Caldaopoli.
Ah, nice.
Yeah, that's on Friday, but that's going to be in Italian. So if you speak Italian, I urge you to join, okay?
I can only hear Italian.
I can sing Italian sometimes. Anyways, Professor Mazor, thank you very much. It was wonderful as usual. And I'm hoping to see all of you again on a future Cometa Bio webinar. Thank you.